Hi everyone, this is Janet Hill at the Rock Island County Health Department. Welcome to our briefing of September 1st, 2020. Today we have with us Dr. Louis Katz, the Medical Director of the Scott County Health Department, Ed Rivers, the Director of the Scott County Health Department, and Nita Ludwig, the Administrator of the Rock Island County Health Department. Thank you all for joining us. Nita, let's start off with Rock Island County's case count, please.
Good afternoon. Unfortunately today, Rock Island County is reporting 3 additional deaths from COVID-19. A woman in her 60s, a woman in her 80s, and a man in his 70s. All 3 had been living in long-term care facilities. And the total number of deaths in Rock Island County is now at 63. We send our deepest condolences to the family and friends of these individuals. We know of at least 31 COVID-19 patients who have died in August, including the 3 today. In addition, we also have 19 additional new cases of COVID-19, and I was looking for the total, and that brings our total to date to 2,266, and 15 people are currently hospitalized in Rock Island County. For a community to respond to communicable disease such as COVID-19, a number of tools are needed to respond effectively and reduce the spread of illness. These tools include social distancing, wearing of face masks or coverings, contact tracing of positive cases, hand washing, quarantining of individuals who are close contacts, isolation of individuals who are positive for COVID-19, and staying home when you show any signs of illness. The reopening of many schools in our community has highlighted the contact tracing process that takes place when a positive case of COVID-19 is identified. We would like to take a moment again to explain the process, the impact it can have on disease spread, and the role of individuals in making this process effective. Contact tracing is used to identify possible spread of disease from a positive individual to any other individuals that they may have close contact with during their infectious period. During a pandemic where virus is spreading throughout the community, called community spread, contact tracing has the goal of preventing further spread of the illness, not pinpointing where someone actually got the virus. Our contact tracers do call all positive cases, and the number that they use looks like a Chicago number, but it's really the Rock Island County Health Department. So we wanted to alert them that if they see this number that I will give you in just a moment here, that it is not Chicago calling, it is Rock Island County Health Department, and to please pick up and answer our contact tracer questions. That number is 312-777-1999. So if you see that number on your phone, 312-777-1999, that is the contact tracer from the Rock Island County Health Department, and please pick up and answer our questions to prevent the spread of this virus. Thank you.
In Scott County today, our cases stand at 2,235 and deaths are at 21. Contact tracing follows very similar steps in Scott County. The process started when the local health department receives the positive test result for an individual. This process happens regardless of how the individual may have contracted COVID-19. If you're called by the local health department, please answer or return our call after we leave you a voicemail. Here's what to expect. For positive individuals, you'll be asked a series of questions by the health department staff to determine when you would likely have been contagious and who you spent time with during that period to identify who may have been exposed. You will be asked to self-isolate for at least 10 days and will be given advice on how to take care of yourself during self-isolation. And you'll be free to ask any questions you might have. For contacts to a positive case, you'll be told you've been exposed to a positive case of COVID-19. You'll be asked to quarantine yourself for 14 days from your last exposure to the case to make sure you don't spread the virus to others in case you develop COVID-19. You'll be given advice on symptoms to watch out for, and you'll also be free to ask any questions you might have. It's not anyone's first choice to have to stay home from work or school for an extended time. However, as community spread of COVID-19 continues, this could happen to any of us. If you find yourself in a situation where you're getting contacted by public health, we simply ask you to do your part. Take our phone call, answer our questions, and follow our guidance. You'll be doing your part to help keep the virus from spreading further.
Thank you, Ed and Nita, for that information on contact tracing and the process that's currently taking place. Next, we'll hear from Dr. Katz, Medical Director of the Scott County Health Department. So go ahead and give us the information that you have prepared for us today. Thanks, Dr. Katz.
Okay, Brooke, are you going to show that graph?
Yes, we will work on showing that right now.
Okay. So what we're going to show you is the Scott County epidemic curve. The Rock Island County curve looks very similar, and the exact numbers are not critically important. But what you see, the blue bars are the case counts, and the red line is 14-day moving average. And you can see that we had a small peak in April and a big surge beginning in June and continuing to date. We were very hopeful into mid and late August that we were going to continue downward as we approached the time when school would open. But as you can see, over the past approximately 2 weeks, we've been on a steady upward trend, and we're running just under 30 cases per day in the 2-week moving average. So that's a rate or an incidence of approximately 20 cases per 100,000 population per day. To put that in context, the incidence rates at which people, public health officials, begin to feel pretty comfortable with a lot of face-to-face learning opportunities in the school would be between 1 and 5 cases per 100,000 per day. So I think the rates that we're seeing should make us very cautious as we try to reopen schools over the next several weeks. In addition, we show you the 14-day test positive rate. This is the moving average over 14 days from the Iowa website, 7.4%, which has been rising from about 6% over the last several days. And again, for context, I feel much more comfortable about reopening interventions when we get that rate continuously below 5%. So not the news we'd like to see, but those are the numbers. I've been asked about the age distribution of cases in Scott County, and we know during August, approximately 13 to 15% of our cases were in the K through 12 age groups, and the rest very widely distributed above that age, with a lot of cases in young adults, and increasing number of cases in older adults. I was asked why we put a contact to a confirmed case in quarantine for 14 days, but an actual confirmed case is in isolation for only 10. It's actually fairly simple. The 14-day self-quarantine for contact is from the last day of contact with a positive case and encompasses the longest incubation period for the infection. An individual who's already positive is already, on average, 5 or 6 days into their infection. So doesn't have to stay in isolation quite as long as the contact does. We know that in people who are infected with illness and have COVID-19, in fact, the virus is gone from their upper airway probably between day 7 and day 9 or 10. So 10 days of isolation for a case is really all that's needed and is reasonably conservative. The other question I was asked had to do with whether a patient with an individual, who has contact with the case is quarantined for 14 days, regardless of the use of masks or not. And the reason for that is basically that masks are a form or an intervention that we use as harm reduction, not harm elimination. We believe masks are very effective, but they're not completely effective. So public health guidance from both CDC and the state asks us to not consider in a contact situation whether masks were being worn. So that's all I had.
Thank you, Dr. Katz. We do have a number of questions. I think I'll start with some that are in the chat first, and then we did have some that came up prior to the call, but I think those on the chat relate to some of the information you just shared, so we'll go to those first. One question is, who should people believe when it comes to information and statistics? Where should they look for reliable information? It says even the CDC appears to contradict itself sometimes, and people can be frustrated. So what is your suggestion for where individuals should look for information related to this so they can make decisions for themselves and their family?
Well, they can always reach out to the health department. And it is true, we access a lot of information that isn't easily available to the public. So what appears to be contradictory can actually be contradictory, but much more often represents our evolution of understanding. We said something 2 weeks ago, but the evidence is evolving so quickly that it changes now. So I believe that the CDC and the state health department websites are in fact very, very excellent sources of information. When you find them confusing, reach out to us and we'll try and make sense out of the confusion that you're having.
There's another question on the chart that you shared, and I'll give a little sort of pre-information for this. It's regarding the epi-linked cases. So both health departments do the interviews that come with positive cases, and so there's some additional information that is gathered from that connects to some cases who may end up having symptoms and things like that. Can you give some further explanation about what it means for epi-linked cases and how that compares to actually the confirmed number of cases in our community?
Yeah, we have, in our case counts, which are a little higher than what you get from the state, we include what are called epidemiologically linked or epi-linked individuals. Those are people on whom we don't have a confirmatory test result, but who were contacts of a confirmed case and have symptoms. So it's a very standard approach to infectious diseases epidemiology. So, for example, in our STD clinic, if somebody is a contact to a confirmed case of gonorrhea, we treat them and don't wait for a test result to come back. We usually test them, but we don't wait for the test result to come back because they're very, very likely to be infected. And it's the same with COVID-19. If you have symptoms and you were a contact with a case, you're very, very probably going to confirm. And so we put those people into quarantine as epidemiologically or epi-linked cases.
Next question would be for Rock Island County, so either Janet or Nita. The information that Dr. Katz shared is based on the data that he has from Scott County and the graph he makes based on that. Is there a similar graph that Rock Island County would have? And for both, is there a way that the tracking of deaths over the same period of and a 14-day average could be graphed in a similar way?
Janet, I'll take this and you can add on if you so choose, but we do have some graphs that we have been doing here internally, and we could share them. I don't believe they have the rolling average, but they are much the same. And then our metrics are actually on the Illinois Department of Public Health website that can show you the positivity rates for Rock Island County. And as of right now, it is 6.6%, which is down a little bit from the last reporting period, but still higher than we would like to see it. Janet, do you have anything to add?
No, I don't.
Anita, there's another question for you. It says, unless my data is wrong, about 80% of deaths in Rock Island County are of patients living in long-term care. What could be done differently to protect the elderly, disabled, and most vulnerable?
Yes, you are very accurate there. Most of our deaths, unfortunately, have been in long-term care facilities. And it is unfortunate because many, as you know, many of these patients have lots of underlying health conditions, heart problems, respiratory problems. Any number of things can make COVID-19 even more serious. And what really can be done is that everybody is practicing these same precautions that we've been talking about with the frequent hand washing. Of course, they are using the proper personal protective equipment, and we are still supplying long-term care places with the proper PPE from the health department. And the other thing is all of the people that are coming and going out of those facilities, whether it's delivery drivers or healthcare workers or food prep people, they all contribute to, what is happening there. I'm not blaming anyone, but everyone needs to kind of take into consideration where they do on their off time. So are they attending large gatherings? Are they interacting with people who may or may not have the virus? Really, people need to be thinking about that and taking that into consideration when they go out places, because as we all know, there can be people that are symptomatic and still not know that they have the virus, and then maybe go to work and spread it totally, unintentionally to this vulnerable population.
Next question, I'll have Dr. Katz answer this. Do you have any idea how many positive test results may be duplicates or from the same patient? And perhaps you can also speak to the amount of time someone could potentially test positive regarding antibodies and things like that.
Yeah, we don't have duplicates in our spreadsheet. We have enough quality control to make sure that we're weeding out anything that's a duplicate. Those are all individual patients are only counted once at this point. The duration that people can test positive is a really fascinating question, and it's too bad we don't have enough time to go into a lot of detail. The test that we use, called nucleic acid amplification to confirm cases, turns positive, generally speaking, in a time frame of probably anywhere from 4 to 6 or 7 days after the exposure. That is, the virus has to grow enough in the airway to have enough there to be detectable. We detect not the virus, but we detect a short fragment of its genetic material, not the live virus. So that test stays positive for many, many, many days after the virus itself is no longer viable. And there are actually reports that that PCR test that we use can stay positive even for as long as 2 to 3 or 4 months in the noses of a few patients. Usually it's gone by the 3rd or 4th week of infection. Antibodies come up in people who are symptomatic, antibodies become detectable. That is the immune response to the virus, as opposed to the virus. The immune response to the virus becomes detectable generally at the end of the first week of infection. Probably by then, half or 60% of people will have antibodies that can be measured with a good test. Those antibodies then peak at about 4 weeks after infection, and depending on which antibody you're measuring, they appear to persist for months, but do decline slowly after reaching that peak at the end of the first month after infection or into the second and third month. Depending on which antibody, what kind of antibody you measure, I suspect that we'll find that some antibodies persist for many, many months.
Ed, we have a couple questions here for you that we could have you address. Are individuals that test positive and are asymptomatic being asked to quarantine?
Absolutely. We believe that asymptomatic individuals who shed the virus are probably responsible for between 30 and 50% of transmissions. The people who are either asymptomatic for the entire course of their infection or haven't yet developed symptoms but are shedding virus. When people get sick, so let's say that you were exposed a week ago and you get sick today, you were probably shedding enough virus to infect people for 48 and even 72 hours before your first symptoms. So 2 to 3 days before illness develops, people can be transmitting, and people who never develop symptoms can probably transmit for a total of somewhere in the range of even up to 9 or 10 days.
Follow up to one of the other questions. We know that epi-linked cases are sort of a presumptive way to see the spread of disease in the community, and that some of those epi-linked cases may eventually be confirmed cases. But do you have an idea at this point of what percentage of cases are epi-linked versus confirmed?
I think about 10% of our cases are epi-linked, maybe a little lower than that. I think it's a little lower than that. It's not a big chunk, but it's not trivial.
Ed, we have a question here for you regarding some stats on the Iowa Department of Public Health website. What can we learn from the antigen stats that are now showing up on the state website?
I'm going to defer to Dr. Katz on that one.
Oh, okay. Well, instead of detecting the nucleic acid, the genetic material of the virus, antigen tests detect proteins from the virus. And unlike the nucleic acid test, they don't amplify the target that we're trying to detect. So they're less sensitive. That is, they're less likely to be positive in somebody who's infected, but they're pretty good tests, particularly in people with symptoms. They're really reasonably sensitive. They're okay. And they also have a few more false positives, many more false positives than the nucleic acid test. But they're rapid, they're relatively cheap, and can be used quite effectively, particularly in patients, in individuals who have symptoms.
So as you're talking about that type of test and the nucleic acid, if you're not testing for the live virus, but for a fragment of material, what fragment are you testing for?
Well, it's a stretch of the genetic material of the virus. The virus has 29,000 bases in its genetic material, its genome, chromosome. And we detect a stretch that I believe is about 20 bases long. Very tiny fragment, but it's very, very highly conserved in the virus. So we don't miss very many with it. The misses that we see with nucleic acid testing are related to two things. One, testing too early or too late so that there's very little virus left. And the other is a poor sampling technique. You've all seen pictures, and some of you have probably been tested. The standard approach is to stick a swab all the way from your nose all the way back to your throat. It's very uncomfortable, and it takes highly trained people to do it properly. So if you don't get a good sample, you may miss the virus as well. But nucleic acid tests are very, very sensitive. That is, they don't miss very many when done properly, and extremely specific. That means when they're positive, they're true positives. They're not false positives. So nucleic acid testing is really the best way to confirm cases.
Okay, and then we do have a couple of questions that came prior that are not in the chat. And so this could be for Dr. Katz or for Ed. White House experts are warning Iowa leaders that the state has the country's steepest coronavirus outbreak and that the state should close bars in 61 counties and test all returning college students for the virus. Why is Iowa seeing such a spike?
Ed?
Well, if you'll recall back during the period from March through the early part of June, there were restrictions on restaurants and bars and other public gathering places, and it was shortly after those restrictions were lifted that we saw our July peak. The effectiveness of our measures in preventing this disease rely totally on the individual. As long as the individuals follow the advice that the local health departments give them, they should remain relatively safe from the virus. But it's clear that over the summer that discipline is eroded, and hence we've had the July peak and now the increasing numbers in August and early September.
And another question was related to a mask mandate and the ability to implement that statewide. While we obviously don't have control of that, any information you want to share on either of that?
Well, what we've been told by the governor and the attorney general of the state of Iowa is that local jurisdictions cannot pass any measures more stringent than are in the governor's declaration of disaster emergency. So that means no local mask mandates because they're not enforceable. Some jurisdictions have passed them and have said that they will enforce them, but I haven't heard of any actual enforcement activity, and likely any penalties that were intended to be imposed would not make it through a court of law.
Dr. Katz, would you like to take a minute and just talk a little bit more about the role of masks and the benefit of masks in slowing transmission? I know we've been talking about them specifically within school settings as well as in any indoor areas or where people can't social distance. Can you just give a better description of how that works?
Well, they work two ways. The relative contribution of the two ways is not 100% clear, but they work in two ways. One is source control. That is, if you're infected and expelling droplets when you talk and breathe and shout and sing or cough and sneeze, they stop a large proportion of the potentially infectious droplets. They don't get out to where they can infect another person, either directly or by contaminating the inanimate environment. The kind of masks that most of the public use, cloth masks, are not thought to be as effective as surgical and N95 healthcare personal protective equipment in protecting an individual from becoming infected, as opposed to source control. But they do offer some protection from becoming infected. So it's both ways. I suspect source control is more important than protecting the individual wearing the mask, but both are important and they're highly effective. I believe on this media call several weeks ago, I pointed to a study in the CDC's weekly journal, MMWR, two salon workers in Springfield, Missouri, who were both symptomatic with COVID-19, and over 14 days during which both of those salon workers and all of their clients wore masks, nobody became infected. And that was 139 contacts that were studied that averaged 15 minutes each. Masks are highly effective. They aren't perfect, but they're highly effective, and they are one of the single best methods for harm reduction that we have. The interesting thing about the mandates, there are 31 states with statewide mandates, and the level of enforcement that's being done is very highly variable. But most places don't have mask police who are going around writing tickets. But what happens with a mask mandate is then from top to bottom in society, there's modeling of safest and most appropriate behavior. And the states that have mask mandates see that compliance with mask use goes up very sharply when the mandates are in place, and critically, when all of the leadership in government, public health, and influencers are all seen to be wearing masks. It becomes appropriate behavior, and even absent writing tickets for not wearing masks, they're temporarily associated with excellent outcomes.
Okay, we did have one follow-up question on the nucleic acid test. Is that a nasopharyngeal test or not?
It can be done on a nasopharyngeal sample, that is the deep swab that goes all the way back to the throat through the nose. It can be done on a nasal sample that's a little less deep, probably a little less sensitive, a little bit less likely to pick up a true infection. And there's expanding evidence that tests on saliva and throat swabs can be quite good as well, and they take much less training to do. Obviously, no training to spit in a cup, and a throat swab can be done by a relatively untrained person. So however you try to do it, there are trade-offs dependent on the source of the specimen and the method used. But we make those trade-offs all the time. The simplicity of a salivary specimen, for example, can allow widespread sampling in schools to detect spread of the virus before it gets out of control, for example. Everything's dependent on the population you're testing, how much infection you expect there is, how much sensitivity you demand from the test, all kinds of things that determine how you choose a method.
Question here for you as well. What is the cycle threshold of the PCR test being used in Scott County? We know it's private providers who are doing this, but do you have an indication of what that might be?
Well, there are many different tests being done, but there are mostly, but not all, what are called RT-PCR, which is the method that has a cycle threshold. So the way that nucleic acid amplification works is that in successive chemical cycles, we multiply the amount of the virus by 2. We double the amount of virus in each cycle, so that when you get up to cycle thresholds of 18 and 20, you have a lot of virus there. So think of 2 to the 18th. Isn't a huge number in terms of the number of viruses that might be present. When you get to higher cycle thresholds, like 10 to the 30, like 35 or 40, it has taken 35 or 40 doubling cycles to have enough virus to detect it. It means there's very little virus there. Each test by each manufacturer has data submitted to the Food and Drug Administration for its approval and specifies a cycle threshold based on the developmental work that's been done by the company as they've brought the assay forward. So they vary a little bit from manufacturer to manufacturer. In general, I can tell you that the cycle threshold at which a test is called positive, in general, is in the range of 35, 36, 37, or lower for most of the assays that are out there. We don't routinely get cycle threshold data when we get positive test reports, mainly because most of the assays, in fact, their licensure or emergency use authorization does not allow a quantitative claim, so the laboratories are not allowed to report that information.
Dr. Katz, I know earlier on in the pandemic you were talking quite a bit of some of the undetected prevalence, or what we believe the actual infection rate is in the community. Do you have an indication of what that could possibly be, or what's the general consensus for how to estimate that?
Well, those estimates haven't really changed since April and May, early June. And we believe that it's on the high side of 5 to 10 times as many cases as we count are out there. So if we're seeing 20 cases a day, 20 cases or 25 cases per 100,000 per day, there's probably somewhere in the range of 50 to 200 or so. There's a lot more than what we find with testing and contact tracing.
And is there reason to believe that mortality rates or mortality statistics, would there also be a larger prevalence of that compared to what we know of?
Well, death is a hard endpoint. It's hard to miss. So we think that any underreporting in deaths relates to a couple of factors. One is that cause of death is a very crude epidemiologic statistic. So if somebody gets COVID-19 who has heart disease and then has a heart attack, they may get called a cardiovascular death, not a COVID death. Or if somebody dies at home and doesn't get an autopsy, the diagnosis may be missed. There are a million reasons for miscoding a death. One of the metrics that we look at for influenza every year, and are looking at very hard for COVID now, is what's called excess deaths. So you look at the average number of deaths in a time frame, let's say from March through August, for 5 years previous to 2020, and you look at the deaths from March through August this year, and we'll find excess deaths. And a large proportion of those excess deaths will be attributable directly or indirectly to the impact of the pandemic. So there's the cases of COVID-19 that don't get counted, and there are the deaths of people who, for example, don't seek care for important medical problems because they're afraid to go to the hospital, that contribute to those kinds of excess deaths. And at the end of the day, what I want to know is, in this stretch of time in 2020, how many more people died than we would have expected in a non-COVID year? And we use that excess death parameter to estimate that. It's not perfect, but it's very good, and it's been very, very important and useful for decades as we study influenza annually. There's a lot of delay in reporting cause of death and whatnot, so it's always a lagging indicator. A lot of death certificates don't get done for weeks and weeks after a death occurs, and determining cause of death without an autopsy is often very difficult. But it's a good measure. It's mostly a good measure retrospectively. 6 months down the line, we'll have a very good estimate of excess deaths. Right now, not as good.
Okay, so the last question of today's briefing will just be related to treatments and therapies that doctors are now using, and are they working to reduce symptoms and help to prevent deaths?
Is that for me?
Yes, it is.
Isn't there another doctor on this call? So death rates from COVID have fallen over the almost 6 months of the pandemic in the U.S. Unfortunately, not much of that fall in the death rate is related to things that we do specifically to attack the virus. Things like the antiviral drug remdesivir, things like convalescent plasma that were very actively involved in manufacturing and distributing at Mississippi Valley Regional Blood Center, the use of dexamethasone for people in intensive care do save some lives. Most of the improvement comes from learning about the disease and learning how to support patients more safely and effectively as their immune systems eliminate the infection and allow them to heal. So things like how to avoid putting people on ventilators, mechanical ventilators, which has its own set of very serious complications. Things as simple as how to position a patient when they're on a ventilator. The importance of abnormal blood clotting in bad outcomes from COVID-19 has emerged over the last several months, and the uses of approaches to prevent abnormal blood clotting have been very, very important. So the falling death rate is a combination of the specific treatments we're trying to mobilize, but is heavily influenced by learning about the disease and knowing how best and most safely to support patients when they get sick.
Dr. Katz, once again, thank you so much for joining us today. We appreciate you sharing your wealth of information with the community as well as with us as we continue to provide guidance to all of the different sectors in our community and support individuals and families as they're making important decisions for themselves and their families. So thank you again for joining us. Thank you to our media partners. This call is being recorded and will be posted to the Scott County Health Department's website as well as our social media pages. So should you need to track back to any of the information that was shared, you may find it there. Again, thank you for joining us, and we look forward to sharing additional information with you in the upcoming days. Have a good afternoon.